Psychotherapy is fundamentally about relationships, relationships between therapists and clients. But what makes some relationships work better than others? In this episode, I'm joined by a leading psychotherapy researcher whose work on therapist effects and patient therapist matching has reshaped the way that we think about effective treatment. But first, if you're new here, I'm your host, Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia. Welcome to Psychotherapy and Applied Psychology, where I dive deep with leading researchers to uncover practical insights, pull back the curtain, and hopefully have a little bit of fun along the way. Please leave a comment below, and if you enjoy this conversation, it'd be appreciated if you hit the like button and subscribe to the channel. This episode begins with my guest talking about how he got into studying psychotherapy. So without further ado, it is my pleasure to welcome my very special guest, Dr. Michael Constantino.
I tend to think my pathway has been pretty linear, and I have felt fortunate about that. So I think like as early as high school, I was interested in psychology. Of course, I don't know that I knew what all of that entailed. But then, became a psych major. And I think I was drawn a lot to trying to understand and even create some of my own very crude theories about like self-concept and how self-concept or one self-concept or the makeup of oneself really helped people develop interpersonal effectiveness or interfered with that. So I think I had early on this idea of self and other as sort of a foundational idea of interest. And I probably could have very easily been a social psychologist if I had had certain formative experiences, that took me that way. And in fact, a lot of my psychotherapy research, kind of brings in social psych constructs. We won't necessarily talk about those today, but I've just had a long-standing interest in self and relationships. And so, when I started looking toward grad schools, this idea of interpersonal effectiveness, I was like, oh, so if you're not interpersonally effective, what might you do? Well, maybe go to therapy. And then, of course, light bulbs go off that probably should have always been on, which is like, oh, therapy is a relationship. And in therapy, you're in a relationship, you're probably working on relationships or your sense of self. And Louis Castonguay was doing research on the Therapeutic Alliance at Penn State. And I thought, well, that could be a perfect blend of all of these things. And so fortunately, I applied to work with Louis and got into Penn State. And that was the beginning of a career in psychotherapy research that really centered on, patient therapist and relational dynamics in the context of the therapeutic endeavor.
That's very, like, in you describing that feels very sophisticated for, an undergrad.
I think part of what, I'm probably telling it much better looking back than I would have saying, where am I
Right.
going back then? But, part of it was I never wavered on my interest in psychology. So I immediately became a psych major. I stayed a psych major. I got to work in both clinical and social labs. And it really just seemed like, overly simplistic, but that the idea of, relationship dynamics and how individual self-concepts like bear on those. I just thought it was really interesting to think about a treatment that was not a prescription, but rather a relationship, that there must be people studying that process, right? And I will say, in a very unsophisticated way, it took me a long time to know how to define process research or process outcome research. Even though I was doing it in Louis' lab, I would go to a conference and, one of my former undergrad pals I might have seen somewhere, and they said, oh, what do you do? And I do psychotherapy process research. And they're like, what's that? And I was like, how do I define this?
So how do you define it?
Yeah, so it wasn't, luckily Louis and I got asked to define it for an encyclopedia chapter. And so we had these two really nice, concise entries, about outcomes research really focuses on often comparing full treatment packages and the effect that they have on patients' mental health. Whereas process research really tries to uncover questions of like, how do they work? What are various things that predict outcomes, either within or across different therapies, and really opening the black box of the psychotherapy encounter to know, what does it look like, and what are the things that are most facilitative, and what are things that are most hindering. And so, yeah, so I guess there became a more sophisticated narrative eventually. But I guess I've always been interested in the participants of psychotherapy and what they bring into it, and then the dynamics that unfold.
So this goes into a question I like to ask people. So, for the last 3 decades or so, a lot of psychotherapy research and what I don't know if is, at least was, has been the gold standard is sort of this treatment for this problem.
Yeah. Yeah.
What do you think about that? And what do you think about the potential limitations of that?
Yeah. Yeah. It's really interesting. I think a lot of my research, even before I could have said it in a well articulated way, especially early on, focusing on things like the therapeutic alliance or patient expectations or hope, a lot of that was born out of an inherent um, frustration with the idea that, a one size treatment should fit all. And really, in my mind, reading a lot of things that were about how this treatment should target these problems, which should then result in, post treatment big outcomes. And all of that sounded great, like if you had the perfect candidate for therapy, and they believed in the rationale for the treatment, it fit their understanding of human suffering and human change. And when that works, fantastic, right? And maybe when it works and all of those things align, maybe therapy can be more prescriptive, so to speak. Do this because there are good aggregated data that say this is a good path. But how many times do all of those things align, right? And the idea of of treatment almost being handed out like a pill, or like delivered as though you can control and mask the person of the therapist, and it just has to be something that you learn the skills and then you deliver in the same way to everyone. That was just always really limiting and frustrating in some ways to me. And so I think my early the way I channeled that frustration early on was to say, okay, what are the things that cut across treatments that seem to be helpful? Because then we have these common factors where we don't have to be so biased toward or clinging to, a label, right? With that label often being an acronym, some kind of, treatment that has 3 letters, ending in T. And so I originally got really interested in this idea of common factors, but it was still very much within, the framework of evidence-based treatment is delivering manualized treatments, or at least, theory informed treatments. But my interest at the time was, can we identify any principles, that are just, relevant to all of them, or at least not unique to any of them. And so that was my first sort of take on addressing my sort of own frustrations or ideas of limitations about that model of evidence-based therapies or treatment packages. I was far more interested in evidence-based principles, or just calling it evidence-based practice, which sometimes might mean adhering to certain manualized principles, but other times might mean changing course because your patient tells you this isn't working, or your patient tells you, I don't really believe in that idea of like how people, what you're telling me, I don't really think that's going to be the thing that allows at least me to improve, or I've tried that before, something like that. Yeah. And then I would say a later take on that was really trying to understand more empirically how to personalize. So, not just the idea of can we locate common factors, but can we also find treatments, or ultimately, as we'll talk more about today, providers who are particularly well suited to certain patients? Or can we find moments in therapy that are going to be much more likely to be addressed successfully if you do this instead of that? And doing this instead of that might mean temporarily putting some kind of treatment package on the shelf and changing course, departing. We've called them departure modules because we've tried to test whether there are specific ways a therapist can behave in the face of certain markers like patient resistance. You know, it's not uncommon that a patient at some point will tell you this isn't working, or I don't like how it's going, I didn't like that homework assignment, whatever. And some of our work about a decade ago was to show that being more Carl Rogers like in those moments is better than trying to double down on your agenda or your rationale that you might be using, for example, from a cognitive or some other model.
So for the listener, just to let you know, when you're listening to Mike sort of push back on some of those just this treatment for this problem. Something to know, and we'll get into this, is that Mike has done, he's very much in the experimental world where he's doing randomized controlled trials of these very nuanced processes. And so this, which is one of the great reasons to talk to you, is that, you get some people who sort of push back against the RCT approach in general. And a lot of your work, at least or some of your work as I read it, is you're still doing RCTs, but you're doing RCTs of these other processes in these really sophisticated
Yeah.
and creative ways, which we'll get to in a few minutes.
Yeah.
So, but before we get there, we're going to talk mostly about therapist effects today. So when you say therapist effects, what does that mean?
Yeah. It's a really important question, because actually I've contributed to projects that have been labeled something like a therapist effect. And really what people are talking about are therapist variables, right? Anything that relates to a therapist or that you measure from a therapist perspective is a therapist factor or variable, right? But the therapist effect has a really particular meaning, both empirically and clinically, right? And the classic effect, well, let me first say, to cover the various kinds of therapist effects, it's simply the idea that who the therapist is has some influence on their patient's outcomes beyond the treatment they're using, beyond other characteristics the patients have may possess, beyond different contextual factors. It's simply the idea that some variability in patients' outcome is explained by who they see. All right. Now, the classic therapist effect is referred to as the between therapist effect. And this simply means that if you compared the average patient's outcomes for therapist A, they may be significantly higher than the average patient outcome for therapist B, meaning the average patient on each of their caseloads. So it could be that therapist A and therapist B both saw 100 patients. And if you average their outcome score on some measure, let's say the outcome questionnaire, so symptom and functional impairment, it could be that therapist A's average patient is significantly better in their outcome than therapist B's, right? And that has been replicated, well established meta-analytically. And if you want to put it in,
That there are some therapists that are better than others.
that the therapist significantly influences patient outcomes, and the most simplest manifestation of that, or the most straightforward manifestation of that, is that some therapists are better than others in general on their patients' global outcome. And so, that what that basically, told us, if you want to put it in terms of like percent variance explained, I think that's a pretty easy one for people to understand, that who the therapist is explains about 5% of differences people have or patients have in their outcomes. And if we want to compare that to something like the Therapeutic Alliance, the Alliance explains about 7.5%, right? So that doesn't sound like a lot, but of course, in psychotherapy, there are so many things that contribute to why some patients do better than others, that explaining 5% is significant. And even the variable like the Alliance that we tend to think is the most predictive of outcome doesn't explain much more than that. So it's a meaningful percentage. Now, that kind of classic effect largely stems from having some kind of routine outcome measure that gives you some kind of global score. And then you compare therapists, again, their average patients' outcomes to each other. What we started to become interested in was a second type of therapist effect. And, the first way to refer to it would be a within therapist effect. But I think an easier way to think of it is that therapists themselves have strengths and weaknesses within their own practice in terms of who or what they treat. And so we got very interested in this notion over the past, 10 to 15 years. We have been using a multidimensional outcome measure that looks at different types of problem areas like depression, anxiety, substance use, relational conflict, et cetera. We have 12 scales in this measure that is called the treatment outcome package, or TOP. And we did a lot of preliminary work just to show that therapists indeed have empirical strengths and weaknesses when treating their average patient whose primary problem is depression versus anxiety versus substance misuse, et cetera. And in fact, in the good news department, most therapists show some area of effectiveness or even exceptional effectiveness. And it's often in at least maybe 3 or so of those 12 domains. That's the good news. um, the bad news is that there are no therapists in our thousands of therapists we've studied in this way, who are exceptional at all 12. Perhaps we should have expected that. So maybe that's not terrible news. But there are about 4% of therapists who are either ineffective or harmful in all 12 domains for their average patient, for which that domain is their primary presenting problem.
What percentage you say that was?
4%. So it's not terribly high, but it's a meaningful percentage of therapists are out there practicing. And empirically, their data tell us that their patients either don't get better or sometimes get worse. And so that's the idea of a harmful effect or a harmful therapist effect. But again, we want to home in on the sort of positive ways in which we might leverage this for clinical benefit. And that is, can we learn? And the answer is yes, we can learn it. And we can talk more in a minute about what we can do with it. But can we learn that certain therapists are just going to be better suited to using their talents or their skills or their effectiveness when they're treating certain types of patient presenting problems relative to others? And there are two immediate implications one could think about that, right? Is if we learn that, then that therapist might choose to specialize to what they're excellent at. Or if they're really wed to being a generalist and treating just about anyone who comes through their door, then it might suggest areas where they need more training, or some kind of way in which they can address those areas where they're weaker. And again, weaker can sometimes just mean empirically their average patient who has a certain type of problem is not changing to an expected degree. And all of this, by the way, is when you adjust for risk. So we're not just saying that if a therapist only saw the hardest to treat patients, we would call them ineffective. We would only call them ineffective if those very difficult patients weren't changing to a degree a statistical model would predict they should, even if that degree was just they should change a little bit.
So okay, so there's
risk adjusted. Yeah.
Let's because so you've done a lot of work on this patient therapist matching idea. So could you give us a just general overview and you did one particularly notable RCT where you did this. Could you give us an overview of that project? And please feel free to talk about related, whatever you think would fit for helping the listener understand, oh, okay, this is what they did. This is how this looked or can look.
Right. Yeah. So we had the, several studies where, again, we established that therapists have strengths and weaknesses empirically based on what type of problem they treat. So we had done that. Oh, also, before we get to the trial, the MATCH trial, we had also just done some qualitative research with patients and therapists and other administrators in community mental health clinics, just to say, what would you make of this? And would you be interested in helping in using therapist performance data, so to speak, to inform clinical decisions? And
clinical decisions in terms of who sees
who you might want to see, who you got referred to. Would you want to know that a therapist, for example, had a history of being really successful at treating depression, but they've been less successful at treating anxiety? Would you want to know that? And of course, most patients said, sure, if you could give me that information and you could help me understand it, and those therapists were available, that would be great.
Well, that's, that's what I think about, we have in our lives, people approach you and say, hey, I'm struggling with this, or my sister's struggling with this. Do you have any recommendations? Right. And in your head, I assume you do the exact same thing that I do, which is I think, okay, that's their problem. I know who their sister is or something about them.
Yeah.
Who would be most likely to help that sister with that particular problem? Right. That's sort of the thing we do in that Rolodex in our head.
We absolutely do. And then the question is, what are we basing that on? Is it because we like that therapist, our colleague? Is it because we know they tend to treat a lot of depressed patients, for example? Is it because their website says I'm an expert on this? And all of that makes sense. And that isn't a knock. It's sort of the way it has been, right? Well, so in one other preliminary study to the trial that I'll mention, we also not only measured therapist strengths and weaknesses across these 12 domains, but separately, without therapists knowing their strengths or weaknesses, we gave them a questionnaire that just said, in these 12 areas, do you think you are exceptionally effective, relatively neutral, meaning your patients change right about to the degree we would expect, or do you think you're ineffective or harmful? And it turns out that therapists were no better than chance at predicting their actual measurement based strengths. So, this was the study that sort of built on prior surveys that simply asked therapists, how effective do you think you are? And almost every therapist said, I'm near the top. This was an actual way to show, look, if we measure your actual patient outcomes and we ask you to predict where you think you're really effective or not, therapists are not very good at that. So that tells us when therapists are advertising on their websites, when we are making referrals to our friends and colleagues because we think it's a good fit, there is a good chance that therapists don't know their own areas of expertise through no fault of their own, because of course, how we train, we think that you build expertise by getting certain content and getting certain experience. And that
Well,
is the way our field has been.
and I think like it's just intuitive as well, right? You like at some point you start seeing, right, when you start seeing patients, and well, maybe not when you start, but over time you start to say like, oh man, I really lots,
Nailed
it's this, yeah, I like, it seems like these people with moderate depression I'm really knocking out of the park,
it.
or
Yeah.
the people who are struggling with this transition, or the substance use folks, or whatever it happens to be.
Yeah.
And so like it's just being human. So
Exactly.
to an extent, when I read that in in preparation for this, I was sort of like, oh yeah, that makes sense. We aren't good at like just generally with just insight, right? Humans aren't that great with this sort of predicting
Exactly.
what. But then the more I thought about it, the more I'm like, huh, that actually, I don't know. If you were to put a gun to my head, would I say coin flip? No, I don't think I would. I would say that therapists had a better than average. I'm not saying they're going to be 100% that, but I would think it would be better than 50-50 chance.
Yeah.
And your data don't suggest that. They
They
suggest
don't
we don't
suggest that.
know. We don't
Yeah.
know.
We don't know. More people should do this kind of work. This is a study.
Right.
So like I won't say it, definitively. And I will say some other things about that study. So, one thing is that it seemed to be for the conditions that are most prevalent that therapists treat in outpatient settings like depression and anxiety. That was where we saw the overconfidence bias. Therapists were better at saying, if I see a patient with psychotic symptoms, I'm probably average or maybe even below average. Therapists were far more willing, or at least accurate, to classify themselves in a way that supported their own data when it was for harder to treat, less prevalent problems that they might see in an outpatient community-based therapy setting. So the overconfidence bias tends to be for the things that therapists treat, most frequently.
Mm-hmm.
Yeah. But we seem to understand as therapists that some patients are hard, and I'm not going to judge myself as though I'm awesome at treating them.
Right.
I get it that I'm probably average, when I treat these folks. So I thought that was an interesting little nuance. But anyway, for us, we thought we had accumulated enough data, both the data that established the within therapist strengths and weaknesses effect, the fact that we had patients, therapists, administrators telling us, yeah, I'd be interested in that idea. Um, and the fact that therapists aren't particularly good at judging their own effectiveness in these 12 domains. So we thought, let's apply for funding and see if we can do a trial where the main manipulation happens before therapy. We never changed or manipulated anything about treatment. We went into a community mental health clinic or network, and we basically asked the question, if patients are assigned prospectively and intentionally to a therapist who has a history of being exceptionally effective in treating their primary problem, will that outperform, or will those patients do better by the end of naturalistic, unmanipulated treatment? Therapists just doing what they do. Will those folks do better than ones who were assigned as usual? And as usual fits the example you gave before. They heard from a friend that this person's great. Or as usual for a person walking into an intake center might be, this therapist is available tomorrow.
So
Or,
just to you took half the patients and you assign them to the based on the patient's primary problem challenge, you assign them to the therapists who are supposed to kick ass with that particular problem, and the other half you didn't touch. So some of them, just by coincidence, did end up with
Yes,
the
by
excellent, and some of
chance.
them, right? So whatever, right? Whatever normally happens in a center or in that particular center or that particular network, just
Yes,
let that happen. So
let
we're
it
not
happen.
saying we're putting people with the bad ones. We're just
Nope, there
letting
was
natural stuff happen.
exactly. And indeed, patients in the control group, some of them were assigned to a really good fitting therapist empirically. Yep. And so it's a great way of summarizing it. Two other quick points. One is that the patient and the therapist were masked. So therapists didn't know their historical strengths, even though we measured them. And they didn't know that the intake center was making assignments according to those historical strengths. And the patients didn't know they were being matched or not. The patients only knew that we were doing a study that was looking at different ways to optimize the patient therapist referral connection. That's all they knew. So
Got it.
any effect that I'm going to talk about is it's important to keep in mind that neither the patient or the therapist knew this matching took place, um, and that their highest presenting concern was based on the first thing they did when they arrived at the intake was take the treatment outcome package measure that established their most elevated concern.
Right. And just another real quick point of
That's how we
clarification.
knew that. Yeah.
So when you're talking about the therapists who sort of are like really good at a particular problem,
Yeah.
and you were talking about sort of so you're talking about client outcome in terms of how much you would expect the client to improve. So the way that expect to improve is based on thousands of patients over the years,
Yes.
that like the patient with this particular profile, if you will,
Yeah.
they have a typical trajectory of
Yeah.
improvement,
That's a
right?
beautiful way of saying what was a really sophisticated statistical machine learning model in
Right.
in a reference sample of thousands of patients and hundreds of therapists, right? Yeah, we learned that when patients had certain demographic and clinical and historical characteristics, um, that we could use a model to say this is how much we would predict them to get better on the global outcome score of the top, meaning their total symptomatology, their total level of functioning. This is how much this patient would be expected to change. Yep.
Right. So, right.
And
So if you have with certain characteristics, some patients are going to pretty much all patients are predicted to get better, pretty much. But
yes.
right, that like certain challenges, certain situations, they're going to get better more quickly and
Yep.
versus more slowly. So just,
Yep.
okay, great.
Yeah. So
Okay.
they're predictive. Somebody might come in and be worried well, so to speak, and their prediction is that they're gonna, I mean, that's not a great example because they might have less room to change. But like, let's
Mhm.
say somebody
Mhm.
comes in and they're high distress, but whatever their characteristics are and their history and their personality, their attachment, etc., those things might predict that they're going to change substantially by the end of therapy. And a
Okay.
typical routine outcome monitoring tool at the case level would give you an alarm signal if they're not on track to meet that, right? So that's the typical routine outcome monitoring and feedback literature that's been out there since Mike Lambert's work several decades ago. And we were just basically saying, since we have those data, we can also analyze them at the therapist level. And so what we did was at the baseline of this trial, before we started recruiting trial patients, for the 48 therapists who participated, we spent several months um, tracking how their sort of average patient's pre-post outcome in each of these 12 domains. And we made sure that they had at least 15 or so patients. It turns out we got these performance profiles on a mean of about 28 pre-trial cases. Yep. And so since these are not diagnoses, they're 12 dimensions of symptoms or functioning. Every time a patient completes the top, that adds a patient to that therapist caseload that we are analyzing to classify them in one of three ways for each of the 12 domains. Effective simply means their average patient in a given domain changed more than the algorithm suggested that they should.
Got
Right?
it. Got it.
Their average patient, relative to themselves and their own predicted change rate, changed more than we would expect. That is what we called effective, or maybe even better yet, exceptionally effective.
Right. So
Yeah,
the exceptionally effective. So that grouping of patients or patients with that particular profile, they're basically beating what's expected.
from an
The
algorithm. Yep,
right
yep,
right
yep.
the like if they meet the algorithm, or if they're sort of that's
Yeah.
still, in most cases, those patients are still improving.
Yeah.
Right.
Yeah.
So
We
that's
we
still,
think
in a
we think
way,
of
that
that as a good outcome. Like you're
right.
getting your patients right about to where you would expect them to change. Not exceptional. We called it neutral. I actually don't think that's a great label looking back. But it, maybe think of it more average. You have average outcomes. But your patients are changing right about to where the model would expect them to.
Right. So you sort of expected, better than expected, worse than expected.
Exactly. Yeah, I
Okay.
think now we might, in some of our writing, it's more of like exceptionally effective, or average effectiveness, and then ineffective.
Got it.
And recall that ineffective can be one of two things. Ineffective could be your average patient changes a little bit less than expected, or your average patient gets worse than where they started. And we do know that some patients are harmed by therapy,
Mhm.
and that some therapists are more likely to have patients deteriorate than others. Again, the percentage is low, which is the good news part, but it's meaningful, which is the bad news part.
Mhm.
So once we had, so at the baseline of this trial, 48 therapists had a classification across an average of 28 historical patients, and then we started randomly assigning patients. And again, you were matched, or you got assigned as usual, which meant if you were to be matched, it was purely by chance. And we then looked, to oversimplify our analyses. Did one group do better than the other? And as it turns out, our hypothesis was supported, with a large effect size, a
How many
large
patients were in this study?
large between group effect size. So over 200. I'm trying to remember the exact number per group, but we're
Yeah,
talking about like
over
200.
200.
Yeah,
There you
over
go.
200 some patients. And the to the level that we needed to be statistically powered going in. We saw an effective match that with a large between group effect size. I think the D was 0.75, so close to
Holy,
the
yeah,
point.
that's huge. And I mean, the other thing to note about that is that in the treatment as usual condition, in the control condition, some of those folks are still getting matched to the optimal therapist. So that
Exactly.
really, because I mean, going into that, you had to be a little bit nervous. I would have been that,
Very
like,
nervous,
yeah,
right?
because I mean,
Yeah.
right, in the perfect science, well, I don't know, it depends on what, but like one could say you sort of want to do match to the optimal, match to the worst, right? Like that would be the
If,
cleanest
if,
way.
if, if our goal was to just find an effect, but to have it be clinically murky, yeah, we could have made the control group be like, you're going to get somebody who's not an expert for sure.
Right.
Right.
But so like there is, right, in any study, there still is a chance that your randomization, or your in your case, your treatment as usual, that you would have had lousy luck,
Yeah.
and that a bunch of your patients would have been assigned to a bunch of the best therapists.
Yeah.
And then you would have been, so, but, and so some
And
of
that,
that still
yeah.
did happen. And for that effect size to be that huge is really saying something.
Yeah, and a couple of thoughts about that. I mean, it's a perfect way of saying it. So we were nervous, and we knew that this was a chance that because it was as usual. Who knew if in this particular community, as usual, resulted in a lot of the patients they see seeing a therapist, who had an expertise in that area. Maybe it was a unique therapist sample where there was a lot of expertise in, let's say, depression, and that happened to be a clinic where a lot of depressed patients came, and by chance they got well matched. So we were nervous about that. We were also nervous that we knew we weren't going to be able to capitalize on expectancy effects, right? Because our patients didn't know they were being matched. And in fact, in a future trial, we actually think we'll see a bigger effect of matching if the patient and the therapist know it's happening, right? Because then they would have this
Right.
expectancy effect of like, ooh, I'm seeing a therapist who I know is really good at this. And the therapist is saying, yep, I have this expertise and it's supported by data. And how whatever the mechanisms of expectancies or placebo are, that can be an additive effect to the match itself, right?
Right. And the
Yeah.
expectancy effect, and I think this is where what you're getting at least in some ways, is
Yeah.
that would be more actually what would happen in the real world. So if you worked at a
Right.
center where the typical way of operating was folks got matched to the therapists that are best, but right, that's just what we do here.
Yeah.
Then and the patients got explained that on the front end. The therapists obviously knew that. Everybody knew that. That I mean, maybe there could be some confounds I'm missing here,
Sure.
but
Sure.
like that would be that would be built into the system, which you actually
Right.
systematically removed from your first RCT looking at this.
Exactly. And I'll
Okay.
skip ahead a little bit, then we'll back up to where we are, which is our funder, Patient-Centered Outcomes Research Institute, or PCORI, has also funded us post-trial to do an implementation study. And the implementation work is looking just like you said. The clinics that we're working with in this implementation project are basically just saying, we are just going to adopt this. Our therapists are going to know, our patients are going to know, our intake workers are going to know, and it's just how we're going to do business. So now we have at least a naturalistic way of seeing, without setting up a trial or an experiment, we will have some data to tell us, do we see a bump just if we benchmark people's improvement levels by virtue of being matched to the trial? Do we maybe even see bigger amounts of change because patients and therapists know it's happening? It just becomes standard operating procedure in those clinics. Yeah. But back to the trial, I mean, yeah, we were really nervous, and then we were really excited that we saw an effect. And we, like any trial, we looked at whether our manipulation worked, and indeed, more patients were matched. 100% of the patients were matched in the match group, and I can't remember quite the percentage, but some in the as usual, but like you said, not enough to dilute the effect.
Like less than 25%?
Yeah, less than that. Yeah,
Okay.
exactly. So that also told us what was happening by chance in this clinic. Yeah, right. Yeah, about less than a quarter of the people were getting um, matched by chance to a therapist who was empirically good fitting. And so we found this effect. We also found um, an expected and then an unexpected moderator of the effect. So the effect became stronger, perhaps unsurprisingly, for patients who presented with the most severe pathology, right? So for patients whose overall score on a measure of symptoms and functioning combined, when that was more severe at baseline, being matched was even more effective for that group. And another way to put that is for the patients, and we might come back to this later when I think you might end up wanting to ask about pushback on some of this stuff. We'll come back to this idea, but another way to say that is for patients who are less severe. So for the patients with milder pathology entering treatment, matching really didn't matter. Those patients could see just about any therapist.
At all. It didn't matter at all.
It didn't matter, right? Right. At least at an aggregate between group level, matching did not have an effect at the lower end of presenting severity. So we can think about that later in terms of like resource allocation, right? Is it like what if a clinic didn't have a certain expertise, and it's like, well, maybe those therapists who are just average at everything, if you knew that, those therapists are still very valuable resources because they could see the more milder or mild to moderate patients. And we know empirically that those patients would still get better, at least to the degree that we would expect. Another way of putting that is matching to a higher performing therapy really wouldn't bump them up at all. So it was for the most severe patients that matching was almost like doubly effective for them. And the same thing was true for people who identified as a person of color. And that one we didn't expect to find, but in looking back on it, if you think about the marginalization and the harms that these folks have traditionally faced in the psychotherapy world, the somehow, again, they were masked, but somehow they experienced the therapist's expertise in a way that helped translate into better outcomes when they were in that match conditions than when they weren't. We are really interested in following this up to learn more about what that was all about, because it wasn't like we got to tell them, hey, we know you might have had challenging experiences in therapy in the past, but what we're going to do now is we're going to match you to somebody who we know is really effective at working with the problem you have. We didn't tell them that, so it's hard to know the mechanism of that moderated effect, but we hope to understand that better at just an outcome level. Maybe this type of matching is at least one pathway to improving mental health care equity.
So just because I think there's a lot there. So
Yeah.
Okay, so let's jump back real fast just to
Yeah.
put a bow on this. So for the folks who were the most severe,
Yeah.
right? For the folks that were had the most severe symptoms, life disruption, whatever,
Yeah.
that on your outcome measure when they started, for them, matching to therapists who are particularly strong in whatever domain was their most significant, most important, most severe domain,
Yes.
that really mattered a lot in terms of them improving. When you looked at folks who were moderate severity, we're just using that language generically, not very, that matching doesn't seem to matter that much.
Right.
Matching on effectiveness for their primary presenting problem
Yeah.
didn't matter that much. Okay,
It didn't seem to help or hurt. It was,
right.
the as usual way of assigning for those milder or mild to moderate cases would be empirically supported.
So
Yeah.
okay, so let's just ruminate on this for a moment,
Yeah.
because I think I'm trying to remember, but I remember some research from a while ago, sort of making the argument that like that what that so not the matching thing, but just generally speaking,
Yeah.
that when you look at really good therapists versus weaker therapists or average therapists or whatever, that the difference does have to do with working with really difficult clients.
So if the work you're referring to now is reverting back to the idea of the between therapist effect. So just
Right.
generally speaking, when therapists have differences in overall effectiveness, not domain specific, it is true that one of the things that amplifies therapist differences is working with more severe patients. And if you think about what that means, it means that when you see a patient who's presenting with severe pathology, some therapists get even better, some therapists stay the same, and some therapists get worse. That is what we mean by the therapist effect getting bigger. The amount of variability explained in the severe patient's outcomes that is explained by the therapist gets bigger. And again, what that means is some therapists will do really well with those more challenging cases, for lack of a better phrase. Um, Others will do about the same, and other therapists will get worse. They'll get really disrupted in their effectiveness by seeing that particular group. So you're right that there has been a long-standing link between severity and the between therapist effect. In this case, it was the idea that severity here, think of it as a patient level moderator of the match condition. And in the match condition, we essentially adjusted for severity because everybody's own expected change rate took that into account
Mm-hmm.
in getting matched to a therapist who had that particular level of effectiveness. So it became this moderator variable for the match condition relative to the control condition. So there it's a nuanced difference, but you're right to say that there's a long history of connecting therapist effectiveness differences mattering more, or in this case, how you leverage those differences matters more when you're talking about high severity cases.
Well, it seems to me like one of the contributions of your work is you took this existing finding of sort of the between therapist effects
Yes.
of some therapists get better, or basically some therapist, like there's not that much difference between therapists when the patient's at a low or moderate or whatever level of function or dysfunction, but at higher levels of dysfunction there is a big between therapist effect. But you sort of took that between therapist effect and opened it up
Yeah.
and said let's get some more nuance of what's going on here, and you extended it by saying, yeah, that might be true that, you know, that on average therapists are, that it doesn't matter so much what therapist when you have mild moderate level
Right.
severity. uh, but what we're seeing is, so the reason, or one of the reasons why at higher levels of severity you some therapists are better and are worse, has to do with this matching phenomena, at least in part,
Yeah.
right? So like this is where, so that really expands that finding to be more nuanced, to say
Exactly.
it's
Yeah.
it's the matching piece that matters. And so so a question, and I guess this might not be anything you reported in in any of your papers about this, but just generally, were the folks who were more, you might not know, but I'm sort of curious, were the folks that were more severe, were they more differentiated in terms of their profile? Like where they had, one, like their presenting problem was like spiked through the roof and everything else was moderate. You know what I mean? Or was it
Yeah.
all
Yeah, I mean, so we, because the top gives you these 12 domains,
right?
you do see variability in like how many standard deviations away from a community sample of non-distressed, treatment seeking individuals are they in a given area. But then you also get this total score across the 12 domains. And that's the score we're talking about here as the moderator of the match effect.
Got it.
And,
Got it.
and so it was really just one score. Of course, there was variability, but I think your question is a good one, that for those who were the most standard deviations away from a non-distressed community norm, did their profiles look like, one or two areas were through the roof and everything else was. We haven't really done a profile analysis like that. I think that's really interesting though, because that will allow us to better know what severity looks like, at least in this sample.
Mhm.
And we might be able to think of other ways to take that into account in case assignment or treatment personalization. Yeah.
Yeah, I'm just sort of thinking about like, what is the yeah, right, just like
Yeah.
right, trying
Well,
to explain what's actually happening
yeah.
here,
What's really interesting about your question is that you're thinking of it like, what does an individual patient's profile look like?
Mhm.
We were thinking of it as, what does a therapist's strengths and weaknesses profile
Right.
look like across these 12 domains? And I will tell you, I don't want to get too into this because I think right now we have a nice, clean understanding of the trial, but we did have levels of matching. So I have been talking about it as matching was simply when a patient when you matched a therapist who had effectiveness in the patient's single highest presenting problem area.
Mhm.
But we also had a higher level of match than that. The highest level of match was when the therapist was effective at treating the patient's three most elevated problems, and that therapist was never ineffective on any of the other domains. So it's like the highest level of match is you have a therapist um, who has strength in your three highest areas of concern, and that therapist is never harmful. That was the highest level. The lowest level of matching, there were five levels. I won't go into all of them, but
Yeah, yeah, but
the middle level is what we've been talking about. You match on your primary concern, one primary concern. The lowest level of matching was simply you got a therapist who was average across the board. They were never harmful, but they also didn't have an exceptional strength in your area. And it turns out that level of matching expectedly did moderate the effect. The match effect was stronger at higher levels of matching, but it was still present at the lowest level of matching, meaning simply getting assigned to a therapist who would not harm you or would not be ineffective outperformed getting assigned to a therapist by chance. So that I thought was really cool. Like the lowest level of our matching still outperformed um, case assignment as usual. And of
right.
course, the more effective your therapist was for more of your problems, and the more that therapist never had any ineffectiveness in any other domains, then the match effect got bigger and it got stronger, of course. But to us, it's like even if you are willing to assign patients away from harm, that can be better than as usual chance based matching.
Well, I
Or
think what you're saying is really interesting because I could totally see. You said, of course, but to me, I mean, I think it's fascinating because
yeah,
one could imagine a threshold effect whereby if the therapist is particularly good with their one presenting problem, or that like there's a certain level of like competence. I don't know if that, or effectiveness would probably be
yeah,
a better term here. If there's as long as they meet that threshold, then it's not really going to make that much of a difference. But what you're saying is it's more of a continuum, right, where sort of like you get more variables if you can match on more of these variables that actually continues to be improve.
it continues to matter. Yeah, exactly. Yeah.
which
So,
and that
so
like
if those therapists exist in a given network, then an intake worker should absolutely try to make that assignment. It's like, oh, right, because our this whole notion is based on um, a system that will produce a short list of therapists for any given patient who are considered empirically well matched at one of our five levels. And so the idea is that hopefully many therapists will show up on that short list. And that some of those therapists will also take the patient's insurance, will also have an opening. But if any of those therapists, when you're taking these other factors into account, happen to be strong on all three of the patient's most significant presenting problems, then try to get the patient to that therapist, right?
Mhm,
But
mhm.
you still know that even if you can't, anybody else on that short list would outperform making a random assignment or just basing it on therapist self-described expertise.
So what ballpark? You don't need to know have these numbers memorized. Like, what percentage of the 200 and something patients were categorized as like high, as severe?
Yeah. Yeah, I'd have to go back to
I
the
mean, is it like
yeah.
25%,
Well,
50%?
it was a continuous variable, right? So
Oh, okay.
there was no particular cutoff. It was a
Okay.
continuous interaction of being in the
Got
match
it.
condition and having more versus less severity. So
Got it.
there's no clinical cut point that we're saying once you get here, you're now moderately severe or very severe. It was a continuous variable, and so it's hard to say like precisely
Right.
when it starts to matter that somebody's severe enough. We just know that as you got more severe, matching mattered even more. And
Mm,
again, we've now talked about three distinct moderators, right? So matching worked better for high severity cases, matching worked better for people of color, and matching worked better when there was a higher versus lower level of match. But even the lowest level of matching worked better significantly than doing nothing
yeah,
in terms.
I think that you have like having these moderator effects. I mean, it's a large study, obviously,
Yeah,
and it's not right. So the fact that you found this
yeah,
for that the amount of matching is almost just from sort of a statistical. It's pretty impressive. I mean, it really speaks to your
yes.
large effect size.
It absolutely does, because you're right. We had 48 therapists and 218, I think, patients, which is big for a trial, but it's not enormous, right? This is not big data we're working with. We are working with big data to establish patients' predicted change profiles or slopes. We are working with big data to establish therapist strengths and weaknesses. But when we talk about manipulating the case assignment for one particular trial, it was a good sized trial, but it wasn't huge. Um,
Right.
and so you're absolutely right that created anxiety going in. Will we find this? But also coming out, it tells us how powerful the main effect of matching was, that you then also saw some of these differential results or amplifying of the match uh, you know condition for certain levels of a patient characteristic or a match characteristic.
So
Yeah,
were there like, you know, did you, how can I say this? So you had the therapists who were particularly good, particularly effective with certain presenting problems or primary problems.
yeah,
Did it look like, and I think it was like about three was the average, I think it was 2 point something, if I
yeah,
remember
exactly.
correctly, was
Strengths,
the
yeah. Mhm.
average number of presenting problems that a person was really good at or primary.
Domains of effectiveness. Yep.
So, yeah, yeah. So did like, do you, do, do you see in those data, like there are, of these 48 therapists, there are some percentage that are expert therapists who have a whole bunch of domains that they're really good at. And then most therapists are good at one. And then there are some therapists who aren't particularly good at any.
Yeah.
Or is it really like, no, when we look at it, a lot of people are really, two, three, four. Does that make sense? Does my question make
That's
sense?
exactly, yeah. If you combine the trial data with our much bigger data sets with David Krause and James Boswell and I and Alice
Mm-hmm.
Coyne, that we other studies we published, it's the latter, right? It's most there, the most therapists are going to be good at three or four domains, right? And I think the highest we see for a handful of therapists is they're good at like 8 of them. Again, we never saw therapists who were good at all 12, right?
Right.
So this notion of the super shrink that has been out there, where they're just good at everything, our data wouldn't say that they're necessarily good at everything. At least when you think about being good in being tethered to presenting problems, right? Again, let's be very clear that what we are talking about right now is problem-based matching. We're not talking about anything else. And importantly, I can tell you a little bit about some of the new work we're doing where we're looking at strengths and weaknesses in other ways, not just tethered to patients presenting problems. But at least when we think of it that way, we are more likely to see that most therapists who are out there practicing in the community do indeed have some strengths in about 3 areas.
Well, I think that for the listener, I mean, I think that this is a really good news
I
story, or at
hope
least
that's good news. Yeah.
to me it is. I mean,
Yeah.
to me it says, that if if you're in training or you're in practice, that the typical person is the typical therapist is going to be good at, and again, we're talking about very specific domains, but
Right.
like they're good with they're really good with some percentage of patients who are really struggling, right, with with particular domains of challenge or
Yes.
struggle.
Yes.
And that's a much more compared to some of the conversations I've had, that's a much more optimistic, I mean, that's the problem of getting client to therapist, right client to right therapist, is as you've demonstrated, a very solvable problem,
Yeah.
right?
Yeah.
It's a software problem. It's I mean, hell, you've already done the programming, right?
If you're
Somebody.
if you're willing to measure patients' outcomes, at least at pre and post treatment, and you have a therapist ID in your electronic health record, then you can get therapist effectiveness profiles in this way. If your measure is multidimensional.
Right.
If you just have a measure that's one global score, then you can get the between therapist effect, but you can't get the strengths and weaknesses. So that you're right that the technology is there. Part of what we're talking about, and maybe the optimism you're expressing here is what I hope will be contagious, right? Is that the main thing is that I don't think clinics are having a hard time anymore with the idea of patients completing a measure, routine outcomes monitoring, which helps at the case level measurement based care. If you are willing as an administrator, a system, and as a clinician to find out what you are particularly exceptionally good at and areas where you're okay and areas where you're poor, if you're open to that, if you're open to knowing yourself, right, then I think it's a solvable problem that we can do matching and we can do nuance matching, right? We can even say, even if what you're finding out is that you're kind of average in this one area, if a patient comes in and overall they're not that distressed, no big deal. Still see them. That doesn't have to affect your job. It doesn't mean your livelihood is in threat. But there might also be a situation where a therapist says, "Gosh, it turns out I'm really, really exceptionally effective at treating. The data tell me at treating depression and I don't know, social conflict, right? I think I'm going to start to specialize. I'm going to start to put those data on my website, really become a specialist, and maybe I'm less likely to burn out because I know my patients are getting better. My patients are better off because they're having this experience, right? So there are various ways you can go with it, and part of the pushback, if you will, has really not been the idea. Surprisingly for us, when we talk to clinicians or clinicians are in an audience of a talk, they're not telling us, nope, I'm resistant to anybody measuring my outcomes. Nobody understands how to like measure outcomes in the way that I do work and whatever. It's not that. It's that they don't want to lose their job or they don't want to get pigeonholed into only treating a certain type of patient. They don't want to believe that they can't improve in areas where they're not doing as well. And so part of what we want to do as a follow up is to really find out if we do more pointed continuing education to areas in which therapists are weaker, do they get better? As opposed to just letting therapists sign up for hours whenever they can. So there are a lot of ways to go with this that don't have to just end up being match, no match, right? There are ways to think about it in terms of professional development for clinicians, and part of it will be their autonomous choice. Do you want to be a specialist based on what you learn? Do you want to improve in certain areas? Are you happy that you're average across the board and just make sure you don't see patients who are really, really severe? For some people, that might be perfectly fine for their practice,
Well,
right? Yeah.
and I think what I'm thinking about too is that based on your data, so if you and I are both working at a center, that for a bunch of the patients who walk in the door, and let's say you and I have different strengths, it doesn't matter if they see you or me because they're going to be at a moderate or whatever level of severity. So then our caseloads are going to be varied, right? But you have
variety. Yeah.
right, and you have 3 areas of strength. I have 3 areas of strength. They don't overlap. So it's only going to be for the quote unquote severe patients where your caseload will have more of those people who are struggling in those 3 areas. Mine will have more of those patients who are struggling in my 3 areas where I have
Yeah.
strength. But
Yeah.
but that's only going to make up, I'm making up this number, 50%, some percent, 50%, 30%, 40, 60%, I don't know, of our caseload, where the rest of it, since they're not as severe, those just get thrown out to everybody.
Yeah, I
So,
think that's one way of thinking about mitigating people's concerns, right?
right, because, and you've written about this, because you've
Yeah,
written about that,
yeah,
that's a concern
that
that,
people have. Yeah,
and it's
yeah.
totally reasonable, which is if all I have are people with this particular problem in the severe group, Jesus, that's exhausting. Right. And like,
Or does a network run out of clinicians who have the necessary strength?
right,
And then it's
right,
like, we do matching, but your shortlist came up to 0. Sorry.
right.
So we're going to have to go back to just randomly picking somebody for you, right? And so I do think there needs to be sort of an interaction or a nuanced way of thinking about populating one short list of good fitting therapists. But I think the way
Mm-hmm.
you explained it could be a manifestation of how therapists still have variety on their caseloads, how administrators can make sure that the right patients get the right therapist, because not every network is just going to have 10 experts in each of the 12 domains that always have an opening, always take the right insurance, always work at the convenient office, right? There's still going to be other pragmatics that matter. And of course, there's also patient preferences, right? So we're also working on an app.
Thanks so much for watching. If you found it helpful, please like the video and subscribe to the channel. I'll see you in the next video where we continue exploring the science of psychotherapy and applied psychology.